Hi, I'm Jamie Batts, your instructor for AMP2. We are continuing on with our lecture on the digestive system. In our previous lecture, we talked about teeth and the oral cavity. We're moving down through the digestive tract, and now we are going to start looking at the pharynx and esophagus, and then we'll move into some of those other structures. So let's talk about the pharynx itself. It is basically this cavity posterior to the nose and mouth, and of course we're familiar with those three regions: the nasopharynx, the oropharynx, the laryngopharynx. It is a common passageway for food and air. And there you see that very common picture, which we should all be familiar with at this point in the semester. Our esophagus is taking that food that wasn't or the substance that wasn't put down into the lungs right through the trachea. All of the food and liquid that goes into our digestive tract comes down the esophagus and takes that food down to the stomach. So it's basically a hollow muscular tube about 10 inches long, and the narrowest point is at the beginning, right up near the larynx, and then it goes all the way down behind the trachea and enters the abdominal pelvic cavity through the esophageal hiatus. The esophageal hiatus is literally the hole in the diaphragm that this muscular tube passes through. It's innervated by parasympathetic and sympathetic fibers. It maintains a resting muscle tone, and basically the lumen is kept closed except when you swallow, in which case, the passing food or liquids will enlarge that space. There is a certain level of control. The upper esophageal sphincter is the band of smooth muscle that prevents air from entering the esophagus, and the lower esophageal sphincter, which is also called the cardiac sphincter, is between the stomach and esophagus, and typically it's contracted and remains closed to prevent the backflow of stomach contents into the esophagus. There are some different layers here. Our esophagus is a little different from some of our other organs. You have a mucosa that's non-keratinized, just like the inner lining of our cheek. The submucosa is there as well, holding all the vessels in place. There's a muscularis externa, which is some skeletal muscle. Right? When you think skeletal muscle, you should think voluntary. And then the rest is smooth muscle. So it kind of transitions as you go down through the esophagus. There's no serosal covering, so that there's just an adventitia of connective tissue anchoring it into place. There you see the lumen is very closed. During the swallowing process, it's initiated voluntarily, and there's three phases. So the buccal phase, this is the voluntary phase where you're chewing and chewing, and then you finally say, you know what, I've chewed this food long enough, I'm ready to swallow it. So you push that bolus or chewed up wad of food against the hard palate, and the tongue pushes it back, elevating the soft palate, basically sealing off the nasopharynx, and then this entry of the food into the oropharynx is going to trigger this reflex of swallowing. So from then on, it becomes reflexive. So the pharyngeal phase is when the uvula and palatine arches sense that the food is there, and the swallowing center, which is in the medulla oblongata, is going to activate and coordinate the peristaltic actions of your pharyngeal muscles and the esophagus. So the bolus is moved through the pharynx down into the esophagus. The larynx is elevated, the epiglottis is folded back, the uvula is elevated, uvula is folded forward so that the food is directed where it needs to go down the esophagus. Then we get to the esophageal phase, where that bolus is pushed into the esophagus and peristaltic contractions push that bolus down into the stomach. The bolus is going to trigger the opening of that lower esophageal sphincter and then enter the stomach. Typically around 9 seconds is how long it takes that food to get through, or the bolus to get through. Liquids are faster, right? Something that's poorly lubricated, I'm thinking of you swallow that chip really hard and it's like you can feel it creeping down. Those take a little bit longer and they might require secondary peristaltic waves. So here are the phases one by one. You have your buccal phase, pushing your tongue up, pushing that bolus back. The pharyngeal phase, now we shut off the entrance to our larynx and our nasopharynx. That food is directed down the esophagus. and then our esophageal phase as the peristaltic contractions of our esophagus push food down into the stomach. You can pause the video here, go back and review. Let's talk about the mesenteries in the peritoneal cavity. These enclose the stomach and most of the intestines. The peritoneal cavity is lined by a serous membrane called the peritoneum. So remember, serous membranes all have two sides. There's a visceral peritoneum, which is, our mesenteries, right? That's enclosing and covering all of the organs. Then our parietal peritoneum is lining that inner surface of the peritoneal cavity itself. So it's lining the wall, and then the visceral is lining the organs. So then you have this space in between the wall and organs. That serous membrane is continuously secreting the peritoneal fluid into that peritoneal cavity, into that space. Roughly 7 liters a day. It's secreted and reabsorbed, recycled over and over again. So it's a very thin layer. And that's to allow our organs to kind of move and slide around each other without, causing friction and irritation. The rate of fluid moving into the cavity is actually accelerated by things like liver disease, kidney disease, or even heart failure. So you can look at a patient and look at where they're retaining fluid, and you might be able to look at other symptoms and hypothesize, I think this is ascites, this looks like liver failure to me. That type of a thing. Maybe watch too much Grey's Anatomy. Just kidding. There's also the dorsal and ventral mesenteries. These are actually formed during embryonic development, and they help hold our digestive tract and all of the accessory organs in place, and they can actually develop into other connections, again, firming up their the organ placement. So this is embryonic development, looking at where these mesenteries are. You can see the liver is one of the first things to form, filtering, right, all that blood that comes in. The dorsal mesentery becomes something called the greater omentum, which we should be familiar with, connecting the stomach and the small intestine, forming that large pouch covering the anterior surface of our abdominal pelvic cavity. Lots of adipose tissue there. The mesentery proper connects the intestine to the body wall, and the mesocolon connects our large intestine to the body wall. The lesser omentum is a connection between the stomach and the liver, providing an access route for blood vessels and other structures coming into and out of the liver, and that falciform ligament connects the liver to that anterior body wall. So these are all different mesenteries or pieces of connective tissue holding everything in place. There's the falciform ligament, our lesser omentum, greater omentum, a nice little cross section. Again, this is super early in development, but over time you can see where these things kind of connect to each other. So mesentery proper connecting small intestine, mesocolon connecting large intestine, greater omentum, stomach and all the adipose, and then lesser omentum is connecting liver and stomach together. With the contraction of our digestive tract, as it tends to move with the contractions, the position of the mesenteries are going to change as well. So some of the segments become more fixed in position than others. Some of the segments of the mesentery proper come into contact and they fuse together. So much of that mesocolon is fusing to the dorsal body wall, allowing for other movements to take place, anchoring everything in place. So the mesocolon fused to the dorsal body wall. Mesentery proper is much less loosely connected so that the small intestines can kind of wiggle and jiggle and contract as needed. This is a cross-section showing you the pattern of the membranes, where they go and how they're formed. And whoops, you can pause the video here, go back and review this section. I'm going to include the stomach in this video. So the stomach has a highly variable size depending on what's in it. It can have a very constricted lumen when it's empty, or it can hold up to 1.5 liters. At this point, along the digestive process, we don't call the food. Remember, we started calling it a bolus when it was chewed up and mixed with saliva. Now we're going to call it chyme, C-H-Y-M-E, chyme. This is the partially digested product formerly known as food, right? That's what this is. This is that chewed up wad that we swallowed and is now mixing with digestive juices. We call it chyme. It's viscous, it's acidic, it's soupy, right? And it's formed from the combination of saliva and food and all of the gastric gland secretions. There's a lesser curvature on the medial side, a greater curvature on the lateral and inferior side that attaches to the mesentery. The fundus is the top, the kind of topmost part of the stomach. The cardia is the section of our stomach which is just beneath that cardiac sphincter, protecting the esophagus there. The body is the largest region. This is where the mixing occurs. And the pylorus is that inferior J shape of our stomach. This is where the majority of the mixing and churning occurs. So there you see the pyloric region, the cardia, the fundus, our greater and lesser curvatures, and the body. You can also see the greater and lesser omentums. There's a cadaver view. Obviously, it's not as easy to depict in a cadaver. So let's talk about the layers within the stomach. So typically muscularis externa has two layers, right? An inner circular and outer longitudinal. Well, in our stomach, because there's a lot of mixing and churning that takes place, there's actually three muscular layers. There's an oblique layer, a circular layer, and a longitudinal layer. There's also ruggi inside our stomach. The ruggi are the wrinkles. They're temporary folds, and they will allow for the stomach to expand when it is being filled. The pylorus itself has a pyloric antrum. This is the part that's connected to the body, a canal which empties into the duodenum, and then the sphincter, which is the actual smooth muscle band, which is going to allow for the chyme to go from the stomach into the duodenum. Now, when that happens, most of us think, well, it just like opens and then all the food like assembly line goes through. It's more like a ketchup bottle squirting chyme into the small intestine. So it's more like a pulse instead of just opening, letting the food move through, and then closing. Just so you can get a nice little image there. So there you see the overall anatomy of the stomach, fundus, cardia, body, pylorus region where we have the antrum, canal, and sphincter. The ruggi or the wrinkles are three muscular layers, the greater and lesser curvature. I'll stop the video here so that you can go back and review this section of the stomach, and our next video will pick up with the stomach because there's a lot to it.